So, um, this is designed to be a little bit of I'd say an appetizer for surgeons who are trying to incorporate this kind of surgery into their practice, and we've also set out to do this in a way that patients understand a little bit what is the rationale behind what we call Supercharged BBL. Supercharged BBL, to simplify, basically means to combine buttock implants and fat grafting in the same surgery, which we do quite a lot. So to understand what are the options in buttock shaping, it basically comes down to four. The first one is being Brazilian butt lift, probably the most frequent way we do it, which is fat transfer only, which tends to work extremely well in the buttocks. Second is supercharged BBL, which we do with patients either want extreme hyperrejection or don't have fat. What we try to generally avoid is buttock implants only, because you don't really get any waist shaping, and you always have a visibility issue, or mostly, or fillers. You know, fillers are really a little bit of generally a no-go. There's only one exception, which is high-density hyaluronic acid fillers, which I would basically submit to you as plan B in patients who are extremely thin and you need to get some kind of cover around the implants. But generally, it's really a second or third option. So this is the kind of reaction you usually have or I find when I speak to fellow surgeons about buttock implants. They kind of go, oh Jesus, this is a high failure operation, which I think basically goes down to something like this. This is probably the biggest multi-center study dating back to around 2012, looking at general complication rates in buttock surgery. And I think if you read this, you want to run away crying, because they come down to a conclusion to a complication rate of 38%. and I think, we always want kind of understanding educated patients rather than clients understand that every procedure will have a complication rate, but not 38%. That's bizarre. And what I'm submitting to you, that we managed by, and everybody I think who really drills himself or herself into this procedure and does it at a high frequency, can bring this complication rate down to a very, very workable rate. I'd say we overall have about 9%. 9% means that these 9% don't necessarily need surgery. 3%, I mean 3 in 100 cases, we want to take surgical action. I think this is a very competitive rate, probably for most surgeons much better than, for example, mastopexy with implants. So what I'm always trying to say about implants are, if you do it with a surgeon who does it frequently, much better than their reputation, and you can significantly reduce your problem rate by simply getting certain protocols to make it work. So that it has a super high revision rate is simply not true. And I think that the truth behind this is that, unfortunately, many guys, at least in my environment, have, for example, extremely high experience with breast implants, and they do buttock implants once, twice, or 3 times, have a problem, and then conclude it's about procedure. And I think this is unjust, because butt implants just have to be done differently. My favorite comparison is, I say, breast implants is like driving a car, butt implants is like flying a helicopter. That's 2 different things. And if you take that in, you will see they're extremely workable, and I submit again, probably better workable than breast implants with implants, which I think traditionally is in the core procedures in any plastic surgical practice, probably the procedure with the highest revision rate. Now, what are these rules? And I try to summarize that in what I call a high five, similar to the Tebbit's rules of the high five and breast augmentation. I think use a double incision rather than one in the center. Blunt dissection. Number 3, I think, is the most important paragraph, saying that use an appropriate implant size. Oversizing the implants is probably the most frequent source for failure. Use drains and supplementary fat grafting. That's very simplified, but I think with these 5 rules you will really stay out of trouble, and this is summarized, and I always say this with, I think, a lot of pride. This is an article we managed to publish in the PRS 2019. Me and my dear friend Danny Delvecchio, who is the world pioneer in EBL fatgrafting, we actually managed to get the best paper award for best cosmetic article of the year, which we're of course very happy about. But however, I hope that this article will contribute to make this procedure a little bit more accepted in the surgical community, because this is where we're trying to break down these high five rules. And of course, you know, like we all always try to evolve our practice, our techniques, and this is basically a short summary of what we've done, let's say, over the last 10 years to make this better. Progressive blunt instrument checks, EBL fat grafting, which was a total game changer for us in this procedure. Then dynamic pocket suspension and dual plane pocket dissection, which is another little improvement to make problems even rarer. Now, with buttock implants, here you see dynamic pocket suspension. I think this animation also shows the limit of the procedure. See the implant goes inside the muscle, and the implant can't possibly be bigger than the muscle, because then you'll definitely have a problem. Dual plane pocket dissection, I just want to briefly touch that. You see, this is what I'd say a typical effect of that you see when you put butt implants only in a slim patient. The gluteal muscle edge will show. Some like that, most don't, at least I don't. So then another option is here to go really under the muscle in the top part and inside the muscle in the lower part, so you get best soft tissue cover in the upper half, and in the lower half you still get muscle tissue between your implant and the sciatic nerve, which trust me, you want to have. This is an anatomical demonstration from a cadaver specimen. Of course, we don't cut the muscle like this in the surgeries, but you see here the upper half goes under gluteus maximus and medius muscle, and the lower half inside. This is for demonstration purposes, and you see here, this is the subcutaneous fat, the soft tissue thickness, which is crucial for the aesthetic outcome. One of the famous on-table shots, and you see here the dark red area goes under medius and maximus, and the lower half just over the exit point of the sciatic foramen will be inside the muscle. And where the little stars are, this is where we put the fat. So that I think altogether is quite a nice combo. You see, I think the results with achievable with this are fantastic. It's a very, very powerful technique, as you see, for your body contouring practice, and enables patients to get very nice results. You usually couldn't do that with fat grafting. Now, I think apart from all surgical issues, there is one thing that I think probably one of the masterminds in buttock implant surgery, I think the guy has done it while I was still in university, who is Dr. Raul Gonzalez. He at the last ISEPS meeting outed a truth which I think really hits it on the nail. The thing you have to be a bit aware of is not only the surgical factors, but the main practice. Buttock implants are a surgery patients have absolutely zero margin of tolerance as compared to the breast. What do I mean with that? Most of the patients who are traveling to us for the surgery have had breast surgery before. Sometimes you see, I'm really trying to be kindness, not so nice results of the breast surgery, which they don't mind, or they might even be happy with. But in buttock implants, you know, patients can sometimes really go mental for something that you only see in a very awkward position. And I also feel, I'm saying this you know, for better patient selection, a better patient mind protection, a relatively high percentage of patients who really fail to differentiate between Instagram and reality. So they often, it's a bit hard, you know, to make them understand that everybody has different physical preconditions and can get different results. However, this is on the side note, but generally I'd say dynamic pocket suspension and dual plane dissection, I think, is an extremely powerful couple to get best possible outcomes in the surgery, and I think a real fuel for your practice. And I think this is an underestimated procedure with extreme potential and possibly, as I'm convinced, a great career ahead in the next decade. So we hope this was helpful, for patients to understand this maybe a bit better, although a bit technical, and get surgeons motivated to include that into their practice. We do face-to-face surgical courses on that, which we love for everybody to come to Marbella to learn this, and for those who like slightly bigger events, we take this opportunity to point out our next big life surgery course, hopefully already in the post-COVID area in June 2021. So stay curious, and we hope to get you animated for this procedure.